So I'm here at AMSA'S Rural Health Summit in Albury with Rural Health Commissioner Paul Worley, who's just given what he describes as a G up to the students. What were some of your messages in your talk this morning, your keynote address?
So it's a great time to be in Albury, a place where states came together, where Australia came together, linking up the different parts. And what I was encouraging students to do is to be active protagonists in linking up all the different areas of rural training that there are across the country. We have opportunities for students to be involved at undergraduate level, in junior doctor, in various fellowship programs, but we haven't really linked it up. And I was encouraging students to think about how to link that up in terms of our Aboriginal culture and what we can learn from the Wiradjuri people here in the Riverina about that holistic understanding of health. So how do we link up primary care with secondary care and tertiary care? That's the nature of the rural generalist. And how do we link up all of the different elements of training from undergraduate, junior doctor, fellowship training, which is the rural generalist pathway, and basing that in country. A concept that Aboriginal people describe really well in terms of the importance to their being, but is really a human understanding of who we are. And if we train in our country, we're far more likely to stay in our country and work in our country. And we no longer have an excuse not to be training people in regional Australia for the whole of their medical education, junior doctor and fellowship training. Of course, with opportunities to go to cities for part of that, to learn what you can learn in a city. And that's not just Australian cities, cities around the world. But where do you call home when you're a medical student? Where do you call home when you're a junior doctor and a fellow registrar? We've got the opportunity to call Albury-Wodonga home for that period of our training. And I was encouraging students to be proactive in creating that sort of medical training system for them and for the people that come after them.
What are some of the challenges that are currently standing in the way of realising this vision of fully training in a rural area?
So there's challenges and opportunities, because in many ways the challenges are really just, well, we haven't done it that way in the past. What we've done is had great medical schools based in our major cities, and they've worked really well for our major cities. However, with the advent of great technology and the experience that we've had over the last 20 years of increasingly getting more and more education based rurally, we now know that there's no excuse not to have the opportunity to be based rurally for your medical school, your junior doctor and your fellowship training. Not bonded, based. Not constrained, but given the opportunity to learn the breadth of medicine that you can experience in a place like Albury-Wodonga or the Riverina as a whole, linking up with Wagga and Griffith and the towns all in between. The main obstacles really is just the status quo and people thinking outside of that box of saying, well, why can't we do that? Of course we can do that. But perhaps our health services haven't thought of themselves as teaching health services in the past. Perhaps that's what we need to encourage our health services to see research, teaching, clinical practice as being just as integral to their model of care and their culture as it is to Monash Medical Centre or to the RPA or to the Royal Adelaide Hospital. And then patients get the benefit of that. We know that patients get better care where we're integrating teaching and research and clinical care. And yet, for some reason, we've thought of our rural health services as being purely clinical and not integrated, not creating an evidence base for what they need in regional Australia, not growing their own clinicians. There's no reason why we can't do that now. And my listening to leaders around the country, I'm hearing again and again from health ministers and from politicians and from civic leaders that they're really wanting to do this, and they don't see any reason now why we can't come together and do this. Yes, we'll have to look at budgets, we'll have to look at funding, collaborating, we'll have to look at pooling opportunities to do this together. It may mean some changes in who's in control of who and all of those sort of things, but in the end, it's what our rural communities deserve, it's what our rural economies need, and we don't have a reason to say no.
You talked to the students about what it takes to be a generalist, a rural generalist. What were some of the sort of attributes or things that you shared?
So, I mean, the first thing is that being a rural generalist is a great life. It's a great career. You can put everything you've learnt into medical school into practice. As the two GP colleges have come together to define rural generalism as comprehensive general practice, emergency care, and those elements of specialty care that rural citizens require to be delivered locally, but you can't have a team of specialists on hand to do that sustainably. So it's that enhanced scope of practice that means that you can be responsive to community need, you can always be learning, you can be part of the community, so you are not only seeing patients as people who come into your clinic, but they are people who you see down the street, who you play sport with, who you go to church with, who your kids grow up with. So it's part of being part of a community as much as it is being part of a medical profession. And these days, most of our communities are not far away from each other, so you don't have to be a standalone practitioner in a community now. You can be perhaps the only doctor in a place, but you're part of a network. You're part of a bigger practice rather than a single solo practice, which was my experience when I started in rural practice in the Mallee, in a solo standalone practice. And we can do better than that now in terms of creating networks. So a great career opportunity. You can be like me and become a Dean of Medicine having been a solo rural doctor, or you can continue to be a rural doctor as part of a network and serving your community for your whole career. All sorts of options open to you.
You've been on the road a while now, visiting all kinds of areas. What have you sort of learned in your travels? What have you seen?
So what I've seen is that we live in a beautiful country. We have courageous people who are living there and wanting better for their communities. There are differences, but there are also a lot of similarities between our communities, and what's happened is that we've learned a whole lot in different places in Australia, and yet somehow there's a mentality that, well, it's different over there, and what they do there we couldn't do here for this and this reason. What I'm seeing is that the principles that underlie that are actually very common and very stable across vast elements of Australia. And if we go down to distill what are the principles of how we can set up a training program, of how we can set up models of care once we have sustainable workforces, how we can organise our health services, then the extent of variation becomes much less, and the sense of isolation becomes much less, and we can start doing things together. What I'm hearing is that people are ready to do that, and particularly here at Albury-Wodonga at the Rural Health Summit, I'm hearing that students are definitely ready to do that.
And just finally, someone asked you a really kind of interesting question, and I think you touched on this in your talk as well, the role of doctors as advocates.
So as university educated people, we have an obligation to be listening to our community and thinking more broadly than just the biological patient who is in front of us at any one time, or even the psychological. It's that bio-psycho-socio-spiritual understanding of what it means to be healthy and what it means to be a healthy community. So if we look at the social determinants of health, we have an opportunity as doctors in communities, along with other leaders in communities, to advocate on behalf of our communities. Certainly that was something that became really obvious to me in Lameroo when we were going through the drought and the depression, that just continuing to treat, if you like, at the bottom of the cliff was not going to get the community to where it needed to get to. So I had to become involved with the local council, with the CWA, with other organisations to advocate for policy change so that rural communities as a whole could be changed, including their health services. And that's a new skill set. So you need to learn that from people who are experts in it, people like yourself who've been journalists and have those skills, people who are engaged in politics, people who are teachers. I needed to go and learn a lot of those skills. What I'm seeing again is that there are a large number of medical students who really want to be advocates for their community. They want to make a difference. And through summits like this, they can listen, learn, experiment, have a go, and be part of teams that can really make a difference to our country.
Thank you very much for your time.